desktop. Maybe. ไม่ใช่เดี๋ยวโอเคโอเค So today I will talk about firstly about the basic knowledge about the ICG, like the property of this substance, and after that I will talk about the clinical application of the ICG in liver surgery. The special property of the ICG that make it very useful in liver surgery is that the ICG is excrete, metabolite and excrete by the hepatocyte into the biliary system. So because of this property, we can use it to make the ICG for the utilize in the liver surgery, and it's very low toxicity of this substance. So we can use it very safely. But the main limitation of the ICG is that this substance is we can detect it by just the spatial camera system, because the wavelength of the fluorescent ICG fluorescent is the near infrared wavelength that the human eye cannot detect it. So we have to use the spatial camera system. So the camera system that can detect the ICG is the camera unit that can produce the light, and after the light is reflected from the ICG, they can detect it. At present, the camera system, it can cooperate with the laparoscopic system in maybe in every the camera system in the laparoscopic, and also in the robotic assisted system like a Da Vinci that we call Firefly. After we inject the ICG into the intravenous system, we can divide the phase of the ICG into the three phases. The first one is early hepatic phase. The second one is the biliary phase, and the last one is the late hepatic phase. In the first phase, the early hepatic phase, after we injected the ICG into the intravenous system, just about 30 seconds to 40 seconds, we can detect the ICG in the hepatic artery and portal vein. And after that, just before 1 minute, the ICG we can detect it in the liver parenchyma. And around 40 minutes to 1 hour, the ICG will excrete into the biliary system that can detect in the bile duct. And the second phase is the biliary phase, as I talked. And the last one is the late hepatic phase. It's very wide range of this phase, because the ICG can detect in the liver around 1 to 14 days after injection. It depends on the liver function and some condition like biliary obstruction. If the liver function is not good, or there are some kind of the biliary obstruction, the ICG will excrete slowly. And the next topic, I will talk about the clinical application of ICG in the liver surgery. The first one, I will talk about the intraoperative liver segmentation. As we know that the liver segmentation is a very important thing that we have to know before performing the liver anatomical resection. In the past, we used the conventional demarcation technique like a dye staining or selective inflow control to see the ischemic area to do the anatomical resection. But there are the main drawback, especially in the repeat hepatectomy patient and the cirrhotic patient, that sometimes the demarcation or the dye injection technique cannot clearly visualize the demarcation line. So in the ICG staining technique for liver segmentation is have a two main technique. The first one is the negative staining technique. When we do the occlusion inflow control like a selective in the segment that we will remove it. After that, we inject the ICG in the intravenous. So the remaining liver will we can see the ICG in it, but in the resected part we cannot see it. So we will do the liver resection after that. And another one is a positive staining technique. We inject the ICG into the portal pedicle that we will remove that segment. In the negative staining technique is suitable for the procedure like a hepatectomy, the sectionectomy, or left side segmentectomy. And positive staining technique is suitable for the right side segmentectomy, or in the case that difficult to do the hilar dissection. This is the example of the case of the liver segmentation by the ICG. The case is the patient is have a hepatitis B cirrhosis and had a HCC around 3.5 centimeter at segment 5. From the CT scan, you can see the tumor at the segment 5. And the main inflow is come from the segment 5 pedicle. And we plan to do the negative staining technique. Firstly, try to do the Grisonian approach of the segment 5 portal pedicle. Encircle it. And occlude it by the vascular clamp. After occlusion, we can see the demarcation line, and after the ICG injection, we can see the demarcation line more clearly from the inferior aspect. And in the anterior aspect. And after that, we decide the transection line. And as the Professor Kim and other speaker talk about this, the main useful of the ICG more than the conventional technique is we can see the intersegmental plane that more clearly identified during the parenchymal transection. And in my experience, especially in the sub-segmentectomy, like in segment 8 or in the segment 5 or something like that, the intersegmental plane is very important because there are no the intrahepatic anatomical landmark like a hidden hepatic vein or right hepatic vein. So if you use ICG in this situation, it's very useful. In this video, in some part we can see it. Like Dr. Rapipat, I familiar with the harmonic scalpel to do the superficial transection. When you do the transection deeper, there are no the anatomical landmark inside. So usually if we don't use ICG, we have to imagine the plane of the transection. But if you have the ICG, you can see that in the resected part, there are no ICG staining. So we can go along this plane. The second of the critical application is about the intraoperative detection of liver tumor. In the HCC patient, most of the patients have the recurrent after the resection. One of the possible explanation is the presence of the small lesions that are missed before the surgery or during the surgery. And from the pathological examination, we can detect maybe around 10 to 20% detect only by microscopic examination. So if we use the ICG for the tumor identification during the surgery, from the report or from study about it, we can detect that the new HCC maybe around 10%. In this study, they can newly detected HCC during the operation 13%. And but from the oncologic point of view, in the short-term follow-up, there are no significant difference of the overall survival and disease-free survival compared between the ICG and non-ICG using. But from some study in the long-term outcome, they can improve the recurrent-free survival, but not different in the overall survival. In the part of the colorectal liver metastasis detection, like the HCC, the liver metastasis have a high recurrence rate after resection. Some explanation is from some metastases that are missed during the resection. And from the many studies compare about the ICG and non-ICG in the intraoperative, they found that they can detect more tumor, especially in the small tumor in the ICG group. And in this study, they show that the recurrence rate is lower in ICG group too. But for the long-term follow-up, there are no difference in the recurrence-free and overall survival in both groups. This is the patient with the colorectal liver metastasis and have a tumor in the segment 3, and we decide to do the liver resection after the chemotherapy. But in the intraoperative, we found a small lesion at the segment 3 too. And from the ICG, we can see that there are the ICG retaining. So we decide to do the resection all of the ICG stain lesion, and from the pathological examination, we can find that there are tumor in all of the resected part. But from the intraoperative detection of liver tumor by the ICG, there are the main drawback that this have a high false positive rate, because in some lesion, like a focal fibrosis or something like that, the ICG can stain more for a long time, more than the normal parenchyma. So we have to use the other modality like intraoperative ultrasound to confirm that is a real tumor or not. And the last one is about the determination of surgical margin. In the study that focus on the pathological validity using the ICG during the liver resection, found that if we remove the tumor and cannot see the ICG at the transection plane, usually the tumor have a negative margin, especially in the colorectal liver metastasis patient, and have a accuracy of this test around 92%. And in this case, this is a patient with the liver metastasis from the colorectal cancer at the caudate prostate. From the CT scan, you can see that the tumor is decreased size after the chemotherapy, and the tumor is near at the posterior portal pedicle. But in this patient, there are many multiple tumor, so we decide to do the parenchymal preserving surgery. So in this lesion, we try to do the non-anatomical resection and make sure of the margin by use the ICG. So in this patient, I focus on the site of the tumor that near the posterior portal pedicle. When we change the imaging into the ICG mode, you can see that there are no the ICG stain on the side of transection plane. So we can have more confidence that there are no the tumor on the transection plane. And from the pathological examination, it shown that there are no tumor at the transection area. And the last part of my presentation is about the dose and timing of ICG in the liver surgery. This is a part that this is the most controversial part of the ICG in liver surgery, because about the dose, have a variation depend on the surgeon, depend on the center, and many studies provide many data about it. So in this consensus guideline, they talk about the dose and timing. So I conclude in this table. And this diagram that you can see in the slide. So my conclusion is the ICG in the liver surgery, especially in the tumor detection, is very high sensitivity, but also it had high false positive rate. And so in the new ICG detected lesion, we should use the inspection, palpation, and intraoperative ultrasound to confirm that there is a tumor or not. And the one thing that I focus is the ICG can penetration just about 1 centimeter of the liver surface. So the deeper lesion, we cannot see it. And the time point and dose of ICG is very vary. So we have to tailor case by case. Okay, thank you.